joining us today for the role of abdominal perineal resection surgery for the management of anal cancer with Dr. Marcus Oosenbrug. And you might recall last month we undertook a webinar on the overview of ostomy management in the setting of anal cancer, which was discussing ostomy management, life living long term. That was with some WOC nurses from Memorial Sloan Kettering. And thinking of it, we felt that this was going to be a nice companion piece to talk about the APR surgery piece as part of that. So sort of before and after, as it were, enabling you to sort of see the whole journey through from the surgery through to the management of an ostomy. So we're really thrilled that Marcus is joining us today. Before we get started, I want to give thanks to the Farrell Fawcett Foundation, who many of you know has supported lots of these over the last couple of years, these expert hour webinars that we're holding. So we're very grateful to them. So Marcus will be kicking us off with a presentation today. As is traditional with these, we'll have the presentation from Marcus, and we'll then open that up to a Q&A at the end. So do have a think about any questions during and after the presentation, and Marcus very kindly has given his time to stick around and answer those questions. So Marcus, thank you so much for joining us. Pleasure for us to have you here. Thank you for making the time, and over to you.
Thank you very much for having me. I'm really excited to do this talk, and I think it's really great that you've set it up in this way as a companion piece to the ostomy presentation, which I seem is really excellent. I'm going to share my slides. Bear with me 1 second. All right, is that showing up all right?
Yes, we're seeing those, and over to you.
Okay, perfect. So thanks everybody. I'm going to just start. I've got no disclosures for this talk. And what I wanted to go over as a brief overview of this presentation and webinar, it really would be great if we can make it interactive later on for the Q&A portion. But I wanted to talk about an overview of the diagnosis, treatment, and prevention of anal cancer, followed by what is the role of surgery in the treatment of anal cancer. And then specifically, as sort of the bulk of this talk, would be what is an abdominal perineal resection, specifically when do we consider it, why is it done, and how is it performed, what recovery is like after surgery, and then some key questions to ask your medical team if an APR is going to be part or may be part of their treatment journey. So as a brief overview, many of you may know this. I'm going to go relatively quickly through the sort of background. But the main risk factors for developing anal cancer, I sort of think of them as breaking them down into two, which are exposure to the human papillomavirus and immunodeficiency. So human papillomavirus is the most common sexually transmitted infection in the world. It affects 1 in 4 Americans. Don't have any UK statistics, but it is the most common sexually transmitted infection in the world. And in most people, the virus is either cleared from the body or becomes latent, ends up in a latent state. But people who are immunodeficient, such as people living with HIV or transplant recipients, have an impaired ability to clear that virus, and as such are at a much higher risk of developing anal cancer. And it's important to note that the human papillomavirus infection can also lead to anal precancer, which are abnormal changes in cells that have the potential to progress to cancer. So we label these as L-cell or H-cell, which are low-grade squamous intraepithelial lesions or high-grade squamous intraepithelial lesions. And that's depending on what we see under the microscope. So in terms of the degree of abnormality of those cells, the further away they look from normal cells that would be present in the anal canal, the higher the grade of those cells. And really importantly, because L-cell and H-cell can be identified and treated, that's why screening is recommended for high-risk individuals to prevent progression to anal cancer. So prevention, the HPV vaccine is recommended for all individuals at age 11 to 12. And we also encourage safer sex practices as well as smoking cessation, because that is an independent risk factor for anal cancer. Screening can take place in a couple different ways. The more traditional test is an anal pap test, which is very similar to, or similar in concept to, a gynecologic pap smear for cervical cancer, as well as an digital anal rectal exam to feel for any abnormal lesions. But an HRA, or high resolution anoscopy, came out, several decades later, and this becomes the preferred test for screening for anal cancer. The test involves using an anoscope, which is a small instrument that's inserted into the anal canal, to identify any abnormal lesions. But the benefit of the HRA is that these abnormal areas that would correspond with these H-cell or L-cell lesions can be treated at the same time. So it's really been a positive development. Because this is a surgical talk, I'm going to focus quite a bit on the anatomy because I think it really explains a lot of the rationale behind surgery and the type of surgery that we do. So to start off, it's really important to remember that although this is the lower GI tract, this is not colorectal cancer. It's an entirely different entity with different biology and treatment. Even though the rectum is just adjacent to it, really it's treated it's very, very different. So the anal canal itself can be broken down into several sections. The first being the upper intestinal type lining, and that's similar to the cells that are located in the rectum and the rest of the GI tract. There's a small band called the anal transitional zone, which is that this figure here, the squiggly line between the darker red and the pink area, which is a transition to the lower anoderm lining, which is the cell types that are found in the lower anal canal. And that's closer in nature to the skin, but it doesn't have any hair-bearing follicles, for example. And then obviously the other components are the internal and external sphincter muscles. The internal are not under voluntary control, while the external muscles are. In terms of the anatomy, one other quick point is that there's a big difference between an anal cancer, a perianal cancer, and a skin cancer. The difference being that the anal verge is what we describe as the sort of junction between the anal canal and the skin. So we consider an perianal cancer is within 5 centimeter radius from the anal verge, while an anal cancer is within that area, and it's something that can be visible upon what we call effacement, or basically spreading the buttocks. A skin cancer, in contrast, is something that's outside of that 5 centimeter radius, and that falls under a completely different treatment algorithm and is treated with a different type of surgery, different type of chemotherapy and radiation. So quick review of diagnosis and staging. So diagnosis of anal cancer is made in the biopsy. You need tissue to biopsy it and analyze it in pathology. And that can be done either in the office under sometimes either local anesthetic if it's needed, or if it's high enough in the anal canal, you may not even need it because there's no nerve endings high up in the anal canal, or in surgery. In terms of staging, we tend to break that up into local staging, which is the area of the anal canal, and then distant staging, so the rest of the body, to get a sense as to has this lesion spread elsewhere. So local staging involves an MRI of the pelvis, and distant staging is a combination typically of a CAT scan, so a CT scan of the chest, abdomen, and pelvis, or a PET scan, which has the difference of it will light up with metabolically active cells. And cancer stage diagnosis depends on two things. The first is the size of that primary lesion, the size of that tumor in centimeters, and the presence of any associated lymph nodes in the area. That's different from colorectal cancer, which is based on the depth of the invasion through the wall of the colon or the rectum. So treatment, I think very important part is that the first line treatment for anal cancer is chemoradiation, commonly called that the NIGRO protocol based off of the first protocol. And that has an 80 to 90% complete response rate. So large treatment, if you were to look at anal cancer overall, the large majority of patients, or the large majority of treatment for anal cancer is chemoradiation. Surgery plays a much smaller role in that case. The first exam takes place at 8 to 12 weeks after the treatment is completed. And then important to note that it may take up to 26 weeks to have a complete response clinically. So it's important to have ongoing follow-up with a surgeon and oncologist that can last up to 6 months before being able to firmly say that this is a persistent tumor or a tumor that may have recurred at that point. So what's the role of surgery in anal cancer? I'll break it down into two different types of surgeries. As I said, APR will be the biggest portion of this talk, but there is a role for local excision, which means a small excision of that lesion for small and early stage lesions. An abdominal perineal resection is the other option for any persistent or recurrent disease after chemoradiation. And ultimately, 10 to 30% of patients with anal cancer end up undergoing an abdominal perineal resection. So persistent, progressive disease, and or local recurrence. So in terms of local excision, this is more of a side note than anything, but there are two indications for this surgery. The main difference here is that local excision only involves resecting, removing that small area of tumor rather than a much more involved operation where we remove all the associated lymph nodes that I'll discuss in a minute. But the two main indications are for small early stage tumors of the perianal skin. So if I just go back to that diagram, that's that 5 centimeter radius outside of the anal verge. As long as those lesions are able to be removed without any involvement of those sphincter muscles. The other indication is for what we call superficially invasive squamous cell carcinoma, acronym is SISCA, and that's something that can be in the anal canal, but it's a lesion that's very, very shallow, so has not penetrated very deep into the wall of the anal canal, and hasn't spread very far. So that's really something that's microscopic, and it's something that's often found incidentally when people have surgery for hemorrhoids or for benign entities, and the pathology will come back as SISCA. And in that case, that tells us that we can leave that as is. As long as it's been fully removed, there's no need for any further treatment. And importantly, as I said, can't involve any of the sphincter muscles because that leads to you need an abdominal perineal resection in that case, and we'll talk about why. So what is an abdominal perineal resection? What's an APR? So it is surgery that involves resection of the lower part of the GI tract. So that's the rectum and anus, as well as all of the lymph node containing tissue that drains it. As part of that, that also involves creation of a permanent colostomy. So that's a colostomy bag. The description here, the figure here shows one. And of course, many of you tuned into that webinar a few weeks ago. Had a really good talk about it. As well as closure of the bottom or the perineal wound, with or without reconstruction when the anus is removed. So an abdominal perineal resection takes place in two portions. There's an abdominal portion and the perineal portion. Part of the surgery is performed in the abdominal cavity, and that's to mobilize the rectum. Think of it just as a cylinder, and this figure here, I've got it circled as really the lowest part of the GI tract, as a cylinder going all the way down to the pelvic floor. That's the abdominal portion of the surgery. The perineal portion is the completion to remove the sphincter muscles and the anus, and that's the dotted lines that you see from below. So that's the perineal portion, removing the anal sphincter muscles and joining up that abdominal dissection to remove the anus and the rectum. So you may wonder, why don't we simply remove that anal lesion? So a local excision in that case, and for all anal cancers. And what about just reconnecting the colon to the end of the anal canal? So just removing that part that has that part of the sphincter that has the lesion. And so the real reason is we need to remove all of the draining lymph nodes because that's how cancer spreads. Secondary reason is that if we removed too much of the sphincter muscles as part of a local excision, then that would result in really poor function. Because as I said, the sphincter muscles are what control continence. The downside obviously would be incontinence in that case. Importantly, the anal canal has what we call a dual lymph node drainage. There's the drainage that goes up into the abdomen along all the blood vessels that feed the upper rectum, such as in colorectal cancer. But it also has a secondary drainage that drains to superficial basins, which are in the groin. So those are inguinal basins. So that's something that we take into account when you do staging. When you go to your provider's office, they'll examine the groins to make sure that there's no abnormal feeling lymph nodes. Surgery can be done either laparoscopically or robotically, and that typically involves either 4 or 5 incisions. The placement depends on the surgeon, depends on if it's robotically or laparoscopically, but they're anywhere between 5 and 12 millimeter incisions in different layouts. And in that case, if it's fully done robotically or laparoscopically, the extraction of that whole specimen of the rectum and the anus can be taken out through the bottom wound, through the perineal wound, which avoids a larger incision. However, there are cases where perineal wound reconstruction actually requires making a larger incision, that laparotomy incision on the right. I'll talk about one of those examples. And in that case, obviously, if that's what's needed to actually do the reconstruction, then the whole surgery would be done through that incision. So the perineal wound is, I would say, a challenging part of this operation because of a few reasons. There are issues that can arise with healing of that wound, and they're associated with higher rates of complications such as surgical site infections, seromas, or buildup of fluid in the pelvis, or if that wound so separating a little bit called dehiscence. And part of that is because of gravity, just the way that fluid pools. You're sitting down or lying down, there's a lot of pressure in that area. But also the fact that when we do an abdominal perineal resection for anal cancer, this is always done in the setting of tissues that have already been radiated, which tend to have very poor wound healing. So very commonly, surgery is performed with a reconstruction of that perineal wound. And typically that's a decision that's made with our plastic surgery colleagues with different types of flap reconstructions. And that's to help mitigate the risks. It never becomes zero, but it does minimize or does lessen the risk of a wound dehiscence, for example. So I'll talk a little bit about flap reconstructions. Now, granted, I'm not a plastic surgeon, I'm a colorectal surgeon, but our institution, we tend to use a lot of VRAM flaps, but there are certainly other options, including gluteal flaps and gracilis flaps. But I'll just give an example of what a VRAM flap looks like in terms of what surgery looks like in the wound. So VRAM flap is a vertical rectus abdominis muscle. So that's reconstruction using your abdominal muscle, and that's commonly used for wound reconstruction. In that case, the whole rectus abdominis muscle and the overlying skin are used to fill that perineal defect. Otherwise, it's too large. And so we typically use the right side since the colostomy is typically placed on the left side. So usually it's the right that's used for this reconstruction. So you can see in the figure here, this is roughly the area that's removed. And so because the incision needs to be made, because the laparotomy or midline incision needs to be made, typically the operation is done through this incision rather than laparoscopically or minimally invasively. What ends up being done is once that's brought down, suture to the skin, and I'll go over a bit of post-op care, but in the end, the result is something like this. So the skin at the abdominal wall is used to fill that defect, covering that, and it heals, often quite nicely. The second portion is the creation of the colostomy. So it's an end colostomy, which is bringing out the divided end of the colon through the abdominal wall. We call it an end colostomy rather than a loop because there's only one opening. It's just been brought up through the abdominal wall. We won't go over this in too much detail because, again, there was a fantastic companion piece a couple weeks ago. But the important thing I want to mention is that enteral stoma nurses are your best friend. They're our best friend too, but they're your best friend in a journey with a stoma. Um, because they are with you through the first pre-op visit, early post-operative visit in the hospital, as well as ongoing visits, as needs arise, in terms of teaching and trying to understand, this big change that happens to people's bodies. So it's really crucial that first meeting with the enterostomal nurse in terms of marking where exactly that's going to be made. So before surgery, people come in, see our nurses, and we'll make a mark on their belly in terms of what's the best location for that stoma. A few things what we try to do is obviously make sure that our patients can see it to be able to actually empty the bag um, or change the bag, and then to also minimize areas where there may be previous scars or skin folds to prevent any leaking of the appliance to try to get the best seal. So that preoperative visit is a crucial visit. Our stoma nurses will also see our patients post-op and the first, usually on the second day after surgery for teaching and then just starting, practicing emptying that bag. Um, it doesn't it takes a while to get comfortable with emptying or at least changing the bag. I think that's one of the important parts that we want to make sure that our patients are very comfortable with this before they leave the hospital, is that they're comfortable emptying the appliance, and have a number to call or someone to reach and get a general idea as to what to happen if you have an accident. But certainly the expectation is not that by the time you leave the hospital, um, that you're an expert or a pro at it. Some people are, and it's amazing, but most people will take some time because it's obviously a big change. And so that's why we have our stoma nurses available for ongoing visits as questions or troubleshooting arise over time. And I'll talk about some of the long-term consequences of a colostomy as well. So what to expect post-op? So typically our patients are in hospital for about 5 to 7 days. Can be a little bit shorter if the surgery is performed laparoscopically. Um, and we follow an ERAS protocol, which means it's an early recovery after surgery protocol. So rather than how patients used to be in the hospital for 7 to 10 days, these days we give people clear liquids to drink same day after surgery, and we're back onto solid food the next day. We really try to encourage early ambulation, up out of bed, walking as early as the first day after surgery. That really helps the bowels sort of wake up after surgery and just get things moving. And multimodal pain control is a big one as well too. So we really make sure to try to minimize the amount of narcotics that we use to get appropriate and good pain control, but to minimize the amount of narcotics which have an effect of slowing down the bowels. Um, in terms of what you can expect in terms of having different drains, anywhere between 1 to 3 drains. Those are small rubber drainage tubing, anywhere between 1 and 3, and that depends on the type of reconstruction that's done with our plastic surgeons. Our main check marks for discharge, how do we know when you're ready to leave the hospital? Whether it's at 4 to 7 days, is that you're tolerating a regular diet, meaning you're keeping solid food down without any nausea or vomiting, that the colostomy is working, that your return of GI function, that you're comfortable at least emptying the bag and have a good understanding of what to do if something leaks, um, that your pain is controlled with oral medication, and that you're up and about walking independently. So typically those drains, those rubber tubes are removed when the output gets low. Can be sometimes just before you leave the hospital. Oftentimes we'll do a post-op check in the clinic in about 1 to 2 weeks to check the wound, make sure everything is healing well. Typically we'll try to organize things such that the plastic surgeons and us in the colorectal team try to stack the appointments together. And a visit with our stoma nurses to both remeasure the appliance, make sure that you're doing okay. Follow-up in 4 to 6 weeks is our standard post-op check to see, how are you healing up at that point. And then it goes on to ongoing cancer surveillance, and that takes place with CAT scans and MRIs, usually annually for 3 years. So what are some of the complications and side effects? This is a major abdominal surgery, life-changing for anybody who has it. It's important to note some of the side effects and complications. One is wound infection and dehiscence of that wound. I talked a little bit about it for the perineal wound, but I mean, this is a risk of any major abdominal surgery. Um, but it's particularly higher in this perineal wound for the reasons we talked about. Something that isn't talked about as much initially, but I think should for people who are undergoing the surgery, just because the high rates that this can happen at. There's no real way to avoid it, but it's something that I think everybody should know before undergoing the surgery is a peristomal hernia. So when we make a stoma, we're making a hole in the abdominal wall essentially to bring that stoma out, to bring the intestine out. Over time, that opening can stretch, and the more that it stretches, that leads to what we call a peristomal hernia, where other pieces of intestine or surrounding fat or other structures can protrude through it, causing a sort of lump on the outside of the belly. That's something that, often needs surgery for down the road to fix. But there are many ways that we try to minimize that and, reduce the impact of that hernia, such as wearing certain appliances or having a hernia belt to try to reduce the bulge. And again, this is another reason why our stoma nurses are our best friends. In terms of sexual health and intimacy, I think this is something that is definitely not talked about as much. Definitely not talked about as much as it should. There are symptoms that are different in females and males. Dyspareunia, so pain with sexual intercourse, vaginal dryness, vaginismus. And in males, erectile dysfunction and ejaculatory dysfunction are both commonly reported side effects. And there's been some great studies, including one relatively recently in the last 5 years, that it was a survey of many patients who underwent colorectal surgery with ostomy, and 50% of patients reported some issues with body confidence. And roughly a similar proportion of patients enjoyed sex less than before surgery. Um, and there's a variety of reasons why that happens. It's a consequence of the chemotherapy and radiation that patients receive as part of treating that anal cancer. Um, but part of it is also the dissection in surgery. In terms of being near in a very enclosed space in the pelvis, there's really no way of working around and avoiding. We try to minimize, but the pelvis is a very confined space with a lot of innervation to sexual organs, and so that's why the rates of erectile dysfunction in vaginal dryness are so high afterwards. But a big third component is also the psychological distress and poor self-esteem that a lot of patients report after undergoing surgery. It's something that I think is lessened by talking about first in clinic. First time that you discuss, having an abdominal perineal resection as part of your treatment journey. And if your provider doesn't bring it up, I think it's important to do so because this is a life-changing surgery. So just to cap off on some key questions that I think you need to ask your medical team if they're not already brought up. The first would be the approach, surgical technical details. Is your surgeon planning to do a minimally invasive or open approach? Can give you an idea as to what kind of incisions to expect. And then along similar lines, will a perineal wound reconstruction be required? And if so, what technique are they planning to use? Is this something that's going to be done with combination with a plastic surgeon? And if so, will that have any impact on the type of incisions you may have? What type of healing you may expect from it? Another one would be, what is a typical post-op course in hospital? Because it really depends on what type of approach you have, if it's minimally invasive or open. And again, there are very particular protocols depending on what type of reconstruction you have. And then, as I said, what type of stoma nurse access is available? Not just preoperative, hopefully every patient gets to meet with them before surgery, but how easily accessible is a stoma nurse in case questions arrive, and what kind of support can you be expected to have when you go home after you leave the hospital? And then really, what can you expect in terms of changes in sexual function, and who can you turn to if you have an issue? There are many different things that can be done. Certainly many of these symptoms do improve with time, but certainly these symptoms need to be treated and can improve greatly with seeing urologists or gynecologists. But I think very important to have that discussion up front for such a major surgery. So thank you again for inviting me to talk. It's been a pleasure. Looking forward to answering any questions.
Thanks, Marcus. That was a hugely informative session. I've learned a lot. You can stop sharing your slides if you wish. I've certainly learned a lot, and I've seen some questions have come in. So please keep them coming. First one I've got. Is there a screening program in the US for anal cancer yet? Just wondering if we're behind the times in the UK. So there isn't a formal screening program for anal cancer in the United States, just as in the UK. To answer that question, Nadine, it's because of that sort of lower risk to the general population. There isn't a sort of formal screening program for anal cancer at this stage. There's certain high risk groups, such as MSM, women with a history of cervical or vaginal or vulval cancers, people living with HIV or immunocompromised. But at this stage, there aren't formal guidelines at this stage for screening in the UK. I've got a question from Misty. Would this be available? Would an APR surgery be available if one has already gone through chemo radiation for a stage 2B squamous cell anal cancer, anal carcinoma recently?
If someone has already undergone chemotherapy and radiation for a stage 2B anal cancer, that would be, so yes, that would be the main indication for it. If there was a recurrence of that cancer, this is assuming that the cancer had disappeared entirely or had been completely, eradicated with chemoradiation. So again, if it's a stage 2B cancer that is recurrent, then that would be treatment for it. And if it had never fully gone away, and this is initial persistent tumor would be the word to use, then that would be another indication for it. But any patient who has a stage 2B cancer needs also to be restaged after their treatment. So you'd be getting repeat CT scans, PET scan, MRI, just to restage things and get an idea as to what we're dealing with before going down the road of surgery.
And Misty, just to answer your second question, yes, anal cancer and rectal cancer, they are different. So the anal cancer being in that final sort of 2 centimeters, rectal cancer would be just above that. So a form of colorectal cancer, it was say. So yeah, that they would be 2 different cancers. And also, as Marcus touched on at the start, the causal agents of an anal cancer being different factors to those for an anal cancer, to a rectal cancer. Is an NGT required for either approach? When is the time for stone functioning? So an NGT for people that a nasogastric tube. I don't know if Marcus, that's something that you can speak to.
Yeah, great question. So we don't place a nasogastric tube immediately after surgery. So as I said, everybody goes onto an early recovery after surgery protocol, meaning clear liquids, day of surgery, regular foods the following morning. However, depending on the length of surgery, depending on there's many different factors, but many patients are at risk of developing what's called a post-operative ileus, which is a situation where the bowels slow down, basically, go to sleep for a while. And that's very hard to predict in terms of how long it will last, hard to predict if it will happen at all, how long it will last. And the treatment for an ileus is to place a nasogastric tube. So to have a tube placed through the nose into the stomach and keep that on suction to prevent vomiting and the consequence of aspiration if it goes into the lungs. We wait for return of bowel function, meaning the stoma starts working, nausea dissipates, the bloating resolves. At that point, we make a decision as to when we can take that nasogastric tube out, but certainly not everybody who has surgery has an ileus, and not everybody needs a nasogastric tube.
Question from Caroline. If a patient has potential other areas of concern, such as questionable lung nodules and potential bone lesions, do you wait to perform surgery?
Great question. All of our patients with anal cancer, all new cases of anal cancer are reviewed at our multidisciplinary tumor board. So I think important to mention that none of these decisions are made in isolation between surgeons alone. It's really a joint decision making, obviously, with the patient, but also with our oncologists, radiologists, radiation oncologists, and ourselves in terms of what we would recommend. So if generally in the presence of lung nodules, we wouldn't start with surgery. We would generally favor, a systemic treatment approach, which would be chemotherapy. But it really is on a case-by-case basis. But typically, if there are lung nodules, that means that the cancer cells have spread toward the lungs and are no longer confined to the pelvis. And so surgery at that point is typically not curative. Again, it's hard to weigh in on an individual case.
Thank you. I had a question that came in advance. Can you speak to the occurrence of urinary incontinence post-surgery and how common that is?
Good question as well. Urinary incontinence after surgery, it depends. So there's I'll put it this way. Urinary dysfunction or issues with urination are not uncommon after surgery. And again, for the same reasons that we talked about before, the fact that we're, working very closely to the nerves that innervate the bladder, which is really just next to the rectum. In terms of incontinence itself, that's a little bit less common because some people will have, temporary urinary, rather than incontinence, urinary retention, so not be able to pee afterwards, which may require, a bladder catheter temporarily. Some people will have urinary incontinence afterwards. It's not that frequent, though, for that to be a permanent issue. But again, these are definitely risks when working in the pelvis.
And in terms of, are there any limitations after an APR surgery in terms of returning to work, exercise, driving? Are there any sort of guidance points around that, or indeed limitations that the patient should keep in mind?
I would say the only strict limitation that I give patients is no heavy lifting for about 6 weeks. No heavy lifting more than 20 pounds for about 6 weeks. And that's really to minimize any sort of post-operative hernia, which depends on the type of incisions that you have, but that's the main restriction I give. That being said, it is a major surgery, so I don't expect anybody to be going back to work, as soon as they leave the hospital. Most people will take several weeks off, probably 3, 4, sometimes a full 6 weeks. But a bigger determinant of, maybe not bigger, but a big determinant of also when you can go back to work is when you've healed from that reconstruction side of things. And that depends on what type of surgery you have for reconstruction. So certain plastic surgeons will have, pretty strict guidelines in terms of activity after, such as a VRAM flap that we talked about. Some will have a period of immobility, so they would want you to be in bed or limited sitting for certain times. So that really is on a case-by-case basis, which, emphasizes the point of the importance of speaking to a plastic surgeon before going and having an abdominoperineal resection, and knowing what type of reconstruction they're planning for you.
And Marcus, is it on the on that recovery side? I don't know if you can speak to this. Is it more people having issues with the abdominal wound or the perineal wound that you're finding that people are having issues with in terms of those the sort of side effects of treatments, ruptures, sutures sort of splitting, that sort of thing? Is there one that's more common than the other in that?
Yeah, I mean, both are any surgery, but both in this case are at risk of developing wound issues, wound-related complications. But the perineal wound is at a higher risk of developing wound-related issues, and that comes back to the fact that this is tissue that has already had, significant dose of radiation for several weeks. And one of the main side effects of radiation is poor wound healing. So that's really why we try to bring in very vascularized, healthy tissue with good blood flow to that area for reconstruction. But the abdomen hasn't been radiated, and so that generally heals better.
Gail says, is this possibly a continent colostomy? That is, can it be trained?
Um, Excellent question. They're not frequently done. We don't typically do them here, typically because over time they sort of lose their continence. But that's certainly something that you can ask your surgeon about. Offhand, I would say there's not many surgeons that I know of who perform those. But it is an option that is described, and some people do them. So if that's something you're interested in, certainly ask about that.
And after someone's had APR surgery, would they be charged the same day? Is there a sort of typical sort of period that they might be staying in hospital following that surgery, or is it a sort of fairly quick discharge following?
Generally, five to 7 days is what we'd expect. Yeah,
Yep.
5 to 7 days. Maybe a little bit faster if everything is done, minimally invasively. None of the, potential things such as post-operative ileus occur. Um, but still, it's major abdominal surgery, so certainly at least 5 days.
Yeah. And I think you said around the checkup period that people go through following in that sort of follow-up care. I mean, I don't know if you can speak to in the cases that you've seen that have persisted sort of following that 3-year checkup. Is there sort of common factors that are sort of the recurring factor as to why someone might need continued monitoring?
You mean after that 3-year period of surveillance?
Yeah.
Not really. I mean, usually we would leave it at, once you're between 3 to 5 years after you completed a course of surveillance, meaning the cancer has not returned, and that's fantastic news. Um, then at that point, we often leave it on an as-needed basis. So we're always available if there's any issues with wounds, stoma, or abdominal pain or something comes up on the CT scan, but you wouldn't need to regularly follow up with your colorectal surgeon at that point.
Mario asks, can wearing a hernia belt help prevent a hernia when returning to the gym? Is it also effective for weightlifting and abdominal exercises?
Many patients like wearing them. Many find that it helps in terms of discomfort, pulling and stretching with a hernia. Whether it prevents it or not, I would say probably not going to prevent it. I think this is something where if it's going to happen, it will happen down the road. But certainly it's our first step that we would use if it were to happen. So great thing to talk to your stoma nurse about, having a hernia belt, using one, particularly with those exercises that you just mentioned, weightlifting, things that increase your abdominal pressure, and put strain on your belly.
And I mean, perhaps sort of going almost going back to before. Could you speak to, are there some really sort of specific factors that would lead to APR surgery versus other interventions? And could you talk about what are those factors that might lead to APR surgery being the choice? Is there also the general health of the patient sort of considered as part of that?
Yeah, that last point is a really good point. So, when we talk about APR surgery, really any operation at all, it's always a risk of the benefits and the consequences of benefits, the pros and the cons of any operation. We obviously want the benefits to outweigh the consequences. So we always start and try with chemotherapy or radiation, unless for some reason that's not possible. And that's something to make as a joint decision with our oncologist and radiation oncologist. Um, but typically, APR surgery is what's offered if that tumor were to recur, or to be persistent, so it didn't actually completely go away. That being said, elderly patients would be the first one that comes to mind. Elderly patients with a small not really all that symptomatic cancer, sometimes we have options of trying to continue with chemotherapy um, rather than undergo a major operation. Or that would be the first one that really comes to mind. Or some of these just, for other medical reasons is not fit to undergo surgery.
Yeah. Please do keep those questions coming in. We have a couple more minutes left. If you do want to, I mean, Marcus, from your extensive experience, I mean, do you find that there are common questions that you get asked by patients prior to surgery? Perhaps you could share some of the questions that you commonly get asked that might be helpful for people.
Yeah, I think, a lot of people, I mean, importantly, the first visit is usually a little bit of a shock when you start talking about a major operation like this. And so the first questions are usually things like, what is a colostomy bag? What is a stoma? Um, and what is my life going to be like that? What is my function going to be like that with that? And then the follow-up questions start to get a little bit more specific, which some of the things that we talked about today. So, what can I do? What can't I do? Especially again with a stoma, things like can I go swimming? Can I go, can I do exercise? Can I lift weights? All things that some of the listeners have brought up, and things that again, to tie back to that really great webinar that the ostomy nurses put on a few weeks ago, that those are the very common questions that people have. Some of the surgical questions, yes, I think it's a good thing to discuss. And I think one of the things that this is indirectly not really answering your question, but going on a little bit of tangent. The one thing that people don't often ask, and I think tell me afterwards in the clinic that they wish they had asked is some of the stuff about sexual function and urinary symptoms and what can I expect down the road because it often doesn't come up. I think providers in general are a little bit. I think part of it is culture. People have not been trained in bringing it up. People feel awkward about it. Patients feel awkward about it. And I think it's just really important to start that conversation because there are a lot of things that we can do, but we can't start helping if we don't know that there's an issue to begin with.
Yeah. If recurrence is thought to be in serosal layer and is not visible on anoscopy, do you wait and see in addition to MRI, CT scans, or go to PET scans or a biopsy? I don't know if you can speak to that.
That's a pretty unique situation. I'd have to review the whole imaging to get a better sense of that.
Yeah. Question from Doe: is APR used for a cancer-free patient who has incontinence?
Yes, that is another indication. Yes, and even that's correct. Not even for anal cancer, there are situations that can lead to incontinence or can worsen our pre-existing incontinence, such as radiation. So whether or not somebody has had anal cancer or has been treated for anal cancer, certainly an APR is an option. It's certainly not our go-to option because it is a major undertaking. In some cases it is, but most often, if somebody has just incontinence as their only symptom, there are many other things that we would go through. So sacral nerve stimulation, sacral nerve modulation, and if it's really that debilitating, then oftentimes we can consider, just an ostomy rather than, resecting the whole the anus and lower rectum.
I've got a question. Is there are there treatments or other options available that can be used to improve ejaculatory dysfunction? You talked about the sort of sexual dysfunction, unfortunately, being a factor. But yeah, is there any treatments or options for if people are experiencing issues around ejaculation?
Yes, there are. Again, I'll give the warning that I'm not a urologist. We work very closely with our urologists if those issues come up. There's sort of an algorithm of starting with medications, and seeing if that improves things. But when it comes to next steps in terms of procedures, or second line medication, our urologists would be the ones that we would refer to. But certainly there are options, and in the context of all that, some of these symptoms just do improve over time, albeit slowly, sometimes over the course of several years, or months to years rather.
At what stage post-surgery is it considered safe or appropriate to begin colostomy irrigation? Is that
I'd say probably about probably a couple weeks after surgery, or even I'd feel comfortable probably a couple weeks after surgery. When we make a colostomy, we obviously bring the intestine out through the skin, and those are sutured in place with dissolvable sutures. Irrigation is generally pretty gentle, just with water to irrigate, just like doing an enema through the anus. There isn't too much risk of the rest of the intestine, as long as it's been probably a couple weeks is a good time that you could start doing that, as long as there's no other upstream connections or any other abdominal GI surgery that's taken place.
right? Marcus, that has been a very enriching discussion and presentation. I hope everyone who's been on here has found it as informative as I have. Ladies and gentlemen, we are at the end of today's session. My greatest thanks to Marcus for making the time to join us, and for you all for being with us. As a word of a reminder, we do have the Anal Cancer Patient Summit on the 18th of October this year. I'm very pleased with how all the preparations are going for that, and we'll be releasing more information around that in the next couple of weeks and months. So do save that date for your diary, the October 18th. But at this stage, I just want to say one more thanks to Marcus for being here with us, and to wish you all a very pleasant rest of your day. Thank you, everyone. Take care. Bye-bye.
Thank you again for having me. Bye-bye.